We'll go with it.
Excellent. Yeah, very good. Good. Okay. Welcome. As Hassan said, my name's Pete, and I'm one of the vascular anaesthetists here. And I specifically did this talk for post-fellowship anaesthetists. So if there are non-post-fellowship anaesthetists in the room, it may be slightly boring. And what I thought that would be entirely useless for post-fellowship anaesthetists is to have somebody tell them how to give an anaesthetic. Because you've had lots of experience and will gain lots of experience from working with lots of people. So me telling you that you should give 20 milligrams of propofol at this point is probably pointless. So what I thought would be much more useful would be to give you an idea of the journey that vascular anaesthesia has gone through in the last 10 to 15 years. Some of the most up-to-date advice and guidance around issues to do with aneurysm surgery, and some ideas about what you might want to do if you are thinking about this in the next few months, years as a job, and how you would go about coming across as appointable at the next appointments committee you go to. I'm not going to talk about thoracic aneurysms either, but I would point you towards this month's BJ Education. There's a really good review article in there which summarises quite a lot of the key issues about thoracic aneurysms in there, with some nice pictures about left heart bypass, which is also quite useful. So if you haven't got that, get it online, get the paper copy, or download the podcast. So vascular surgery in the UK has effectively become its own subspecialty. So vascular surgeons in the UK now have separate run-through training and are not, as they were 10 years ago, allied to general surgeons. So these are true specialists. There's around 450 vascular surgeons in the UK working in 70 hub centres, performing around about 440,000 vascular procedures a year. So that covers everything. That's not just aneurysm, that's carotid, that's limb salvage, shunt procedure, etc., etc. Now, we don't have similar numbers for how many vascular anaesthetists there are in the UK, but if you look at the GPAS standards, you will see that there is a specific GPAS standards addendum just for vascular anaesthesia. So it is also, of course, recognised as a subspecialty in its own right, and that's reflected in the fact that there's a curriculum for vascular anaesthesia, which you're all working in, no doubt. If we talk specifically about aneurysm, well, you know, aneurysm effectively is vast majority of it is related to abdominal disease. Around 90% of aneurysms are infrarenal. It's a permanent dilatation of the aorta greater than 30 mils anywhere along its course, or more than 15% increase in size. It has an incidence of up to about 10%, and it's much more common in men than women. But if a woman has an aneurysm, her risk of rupture and her mortality is significantly higher than a man. So that's something to take into account when you're thinking about pre-assessment and pre-preparation, prehabilitation for aneurysm disease. Aneurysms aneurysms expand in a non-linear fashion, and that's the problem really, because we know, as you well know, that if you have a large aneurysm, i.e. over 5.5 centimetres, and you rupture out of hospital, you are, to all intents and purposes, dead. You have around about, various studies show, somewhere between 80 to 90% mortality, and that hasn't changed. That's a flat curve of incidence in terms of mortality, whether you rupture in a hospital, in an ambulance, or at home. What we want to do, obviously, therefore, is have a program where we could screen patients out who have aneurysm and treat them before they get to rupture, because if you don't rupture and we treat you electively, and a lot of the detail of this will come later, you have effectively exactly the opposite way around in terms of mortality. You have only around about a 5% mortality. So really, the whole thrust of aneurysm disease and anaesthesia for aneurysm disease is to do this electively. So if you're doing an emergency aneurysm, it's debatable as to whether a vascular anaesthetist is required at that point. Anybody standing next to a dead patient can probably do as good a job. You will not change the outcome. So, however, you will change the outcome if you do this properly electively. They don't expand in a linear fashion, however. So you screen someone with small aneurysm disease, you can't say you've got 5 years or 6 years or 10 years because they expand in a nonlinear fashion. But what we do know is that size is probably the strongest predictor of rupture. We also know that preoperatively, there are significant interventions that aren't sexy and aren't interesting, and as an anaesthetist, you're probably not that fussed about. But if you can capture these patients in your pre-op clinics and your rehabilitation clinics, you can significantly make a difference to their outcome. And the biggest thing is to stop smoking. And my clinic yesterday, with 6 patients having CPET for their aneurysm disease, they all still smoked, and they were all still reluctant to even consider giving up smoking. And it's a very difficult battle, but it's predominantly a primary healthcare battle, but it's something that we play a large part into. The things that are in capitals there, so statins and aspirins and stopping smoking, that's confirmed kill. We know that those are good ideas, and we know that if you have discovered to have an aneurysm, you should stop smoking, you should be put on a statin, and you should probably have some form of antiplatelet. What we're not completely sure, and the evidence and various studies haven't completely elucidated yet, is the benefit of beta blockers and ACE inhibitors. But probably Poise told us that if you're already on a beta blocker, you should continue your beta blocker. If you've got 4 to 6 weeks preoperatively, you could start a beta blocker titrating the target heart rate. But if you haven't got that much time, you've probably got a worse outcome in terms of cerebral vascular incident if you start beta blocker. So that's the take-home message for that. But we're going to come to the more updated version of that in a little while. So obviously you have surgical and non-surgical management of aneurysm, but we're going to focus a little bit on the surgical management. Clearly there are 2 surgical techniques that you've all been involved with: good old-fashioned, gold standard open repair, either through a transperitoneal or a retroperitoneal approach, and in a very few centres, a lap-assisted approach for open aneurysm repair. Lap-assisted is a little bit of a misnomer. It's lap-assisted dissection to get to aneurysm, followed by slightly smaller incision in the abdomen. So it's effectively still an open country. So it's effectively still an open repair. And of course, stent or EVAR, which is the big news, obviously. 10 years ago, 20 years ago, there's a picture of a nice standard infrarenal EVAR graft. You've all seen those before. I don't have a pointer, but we can see that it's nicely positioned below the renals with the crown of thorns sitting over the renal orifices. So you're still getting renal perfusion. Clearly, that's a good idea. And the limbs extending to just above the external iliac so that you're still getting perfusion. Lovely picture from Cook, followed by a nice picture from Cook of a fenestrated EVAR. Fenestrated meaning, of course, that you have those window orifices that allow perfusion of the kidneys, and a scalloped or scalloped aperture that can allow you to have single fenestration, 2 fen, 3 fen, 4 fens to preserve perfusion of IMA, SMA, whatever else is needed. Slightly more complicated. Effectively, I'm presuming everyone in the room has been involved at some stage with seeing this procedure. So, UK EVAR 1 and 2 were the landmark studies that I think you should know something about, or at least have heard about, especially if you were going to an interview. Slightly historic now, but not that out of date in terms of the evidence hasn't changed a huge amount. And again, as we go through this, I'll come to what the most current evidence is. But EVARs were effectively first introduced in about the 1990s, and after about 10 years of this technology being available, they needed to decide whether this was the right thing to do. First UK EVAR 1 was really to look at whether this was a safe intervention when compared against open. So UK EVAR 1 was looking at, is this an intervention that we can take in people that have been deemed fit for their aneurysm repair, and how does it compare to open? So it was comparing stent to open in men and women over 60 with large aneurysm, and they were randomized to receive either stent or open. And it was a decent powered study with adequate research criteria, and it was looking for primary endpoint death, secondary outcomes, health-related quality, life years, cost, and reintervention rates. And UK EVAR 1 showed that this was indeed a good thing to do, potentially, and it showed that it had a 3% better aneurysm survival, but not an all-cause benefit. So if you look at the kind of key bit of graph from that study, you can see that there's the blue line for EVAR, blue dotted line for EVAR at the top compared to the red line sorry, other way around. The red line for EVAR, the blue line for open, showed that you had initially a survival benefit, but that survival benefit goes after about 4 to 5 years. So after 4 to 5 years, you have the same outcome in terms of mortality from stent versus open. And so that really is a key thing to take away. That hasn't changed particularly. We are still offering patients EVARs, and I certainly get from some of my colleagues and even some of my surgical colleagues a message that, well, this patient isn't that great, they're probably just about fit enough for open. How about we do an EVAR? That would be a better thing to do, won't it? Well, it won't in the long term. It will if you're only expecting 3 or 4 or 5 years of survival for your patient anyway, in terms of all mortality. But from aneurysm mortality, after 5 years, you're going to be doing the same. UK EVAR 2, because UK EVAR 1 first showed, this is showing a benefit. You know, there's a 3% reduction in survival. They suddenly said, okay, well, let's think about extending EVAR to offering this to patients that previously we'd been turning down or allowing to go to rupture even. So UK EVAR 2 was comparing stent versus no surgery. So somebody who's been deemed unfit to have it, we're now introducing. So this was a significantly more impactful study, if you like, but with a much smaller number, a very small number of people recruited to that. But with the same endpoints. And it showed that there is a very significant 30-day mortality in patients who have been deemed unfit rather, for open surgery. And so the take-home messages from EVAR 2 were, we really probably shouldn't be offering this to people just because they're unfit for open. But if you think pragmatically about what happens in the real life and the centres you work in, I'm sure that you are performing stent aneurysm repair in patients that probably you would, and you've fudged and blurred the lines. So the relevance of these two studies hasn't really been translated into clinical practice. We are clearly doing stent surgery in patients who we wouldn't have even considered for open surgery. But we're doing it, I think, on the grounds of this patient is actually very unwell. Probably their life expectancy isn't 5 years, but we can give them a quality of life. There comes problems with that. What UK EVAR 2 showed very clearly is that if you're unfit, you're unfit, and therefore having major surgery is really bad news. So some form of objective functional capacity assessment is absolutely vital. You can see that by any form of epidemiological observation. 8 million operations in the UK last year with a serious morbidity rate of less than 2%. But in that small subgroup, that 2% subgroup, 80% of those patients have a significant measurable reduction in their functional capacity. And so what's changed in vascular anaesthesia in the last 10 years is a large focus now on that pre-operative assessment of functional capacity being in some form objective, and that being a major part of the decision-making process. Certainly wasn't there when I started as a consultant, and I obviously, just looking at you can tell how young I am, that wasn't that long ago. So we were still just going along the lines of, oh, this patient's been served up for aneurysm. Oh, there you go.
Yeah, I just got to adjust something. Sorry.
Adjustment. Shall I carry on?
Yeah, carry on.
So that functional capacity assessment is absolutely vital. And what we're talking about is how can we do that objective functional or semi-objective functional capacity assessment. We might do that by a variety of things, and I'm sure you all want to, and I will rush towards, because it's something I do rush towards CPET, but actually the evidence for CPET is, and we'll again come on to this later, the most current evidence, is that it's probably as good, maybe slightly better, but it's not a single golden bullet, it's not a silver bullet even, it's a part of a jigsaw. And self-administered questionnaires like the Borg's perceived rating of exertion questionnaire and the Duke's activity status scoring index, which is effectively a semi-objective way of working out someone's MET requirement, are almost as good as CPET when combined with something like 6-minute shuttle walking or 6-minute walk test or incremental shuttle walk. So the Duke's Activity Status Index is an interesting one. Obviously comes out of the US, out of Duke in Carolina, and it has shown, what that graph shows very clearly is that you can absolutely demonstrate that patients that have a significant objective functional restriction, so a MET of less than 8, and METs of 8 that you can get just by answering those statistical questionnaire, rather than having to have the resource or the money or the expertise of a CPET, will have a worse outcome, shorter life, more likely to have an MI or significant cardiac event, a MACE event. That's all Duke tells us. Duke's was all about METs, metabolic equivalents, remember? 1 MET is the oxygen consumption at rest. It's widely quoted as 3.5 mils per minute per kg of oxygen consumption. Sitting in this room, slightly bored, overly hot, maybe somewhere slightly less than that. 1 MET, that's what we're doing now. We universally say to our trainees, and you say to your junior colleagues, when you do a functional assessment, you can ask a simple question like, can you walk 400 yards on the flat, 400 meters on the flat? Can you manage 2 flights of stairs? We're good to go in terms of anaesthesia. METs, and the physiological study for METs was derived from a single healthy volunteer aged 40 in 1978, I think it was. So, however, pragmatically and interestingly, when you do physically measure it, as I do when I'm performing a CPET test, the range is not that huge. It's somewhere between 3 and 4 mils per kg. So maybe 3.5 as a sort of stick a pin in the middle isn't too bad. So I like to do a test pre-operatively, and this is a mandated test by National Vascular Database, AAA Quit, which we're coming to in a minute, that is objectively measuring their oxygen consumption, and that obviously is CPET. Short poll, who's got CPET in their hospitals? Everybody then. That covers all the trusts, presumably. I would imagine that if you don't have access to, if you don't have it in your own trust, there is a pathway that can access it. Last year's BJ Education, nice review of this. Significant editorial article, main page article, last March's BJA, consensus guidelines on how to perform, who should be performing, what patients should. National accrediting society to train yourself in CPET. So if you are interested, if this is something you want to build towards, this is the sort of thing you should be doing, formal accreditation and training through poets, going to the relevant meetings, etc., etc. CPET's great because it's a one-stop whole body, so it's integrative. It's looking at cardiac function, respiratory function, and hematological function, that's effectively. It's not a resting examination. How many of you have usefully gleaned any information preoperatively from a static transthoracic echo? Probably the diagnostic yield of that test is almost as low as it can get. You need something to be, you need the system to be working in some way, because the system isn't going to be at rest post-operatively, especially post-operatively after major surgery. It's going to be working, and this is very reproducibly measured, at 3 to 4 times this. So you are going to be using 10 to 15 METs of oxygen consumption day 1 post-operatively. That defines the surgical stress response after any form of major surgical intervention. So if you can't do that pre-operatively, you're going to be in trouble. Now, you're going to be in trouble, especially if I can't intervene by giving you some more oxygen, optimizing your cardiac status, making sure your fluid status is controlled properly, and your pain and all the rest of it, and try to ablate that stress response as much as possible. Never going to go away. But that's why we're doing this pre-operatively, and why exercise replicates major surgery really very well. It's a standardized, as I said, and as that article in 18 showed, standardized protocolized test. It's not something that just is open to some kind of subjective assessment. It combines some spirometry, obviously the patient's fully monitored, and then a rest phase followed by unloaded exercise, then loaded ramped exercise. That means they're exercising against a predefined increasing resistance of exertion, followed by a period of recovery. And you're gaining data at all of those points. So this is, Phil, Steve Jobs style. This is metadata on a grand scale. The number of data points you get out of this investigation are huge. Whilst you're doing your exercise, we're measuring breath-by-breath oxygen consumption and carbon dioxide production, and of course, effectively, we're doing an exercise protocol ECG as well. And lots of people say, well, it's no good in really elderly patients or patients with skeletal problems, or this lady had bilateral knee and bilateral hip implants, and she was pushing into her 80s, she was perfectly able to perform bicycle ergometry. Okay. Fully monitored, attached to a face mask spirometer with Wasserman or with panel plotting the data as you go along. So we've decided that we're going to take functionally healthy and fit patients. We're going to make a decision about whether they have open or stent surgery based on morphology and a shared decision-making process, ideally involving the patient as well as the surgeons, the anaesthetists, and everybody else. We've decided that we should operate because rupture carries a huge mortality, whereas elective mortality is consequently much less. So you've got to decide when you operate. Is it the moment they hit 5.5? Should you operate on someone who's got an aneurysm at 5.3 or 5.4? Or do you wait till they start growing exponentially? Those decisions are complex, and that's where MDT comes in. And that's where the concept that doing this sort of surgery as a team approach in centres that do lots of it make a difference. That's the practice makes perfect thing. We know all of this because the journey for improvement in AAA management started around about 2005 with the NC-POD report of surgery in need of service. That showed some really significant variations in care. And if you cast your mind back to 2005, you can think about aneurysms being done by colorectal surgeons on a Friday afternoon in between their cholecystectomies or their EUAs. They were done by urologists, aneurysms were still being done. There were still plenty of centres that would do 3 or 4 aneurysms a year electively. And obviously all comers would arrive to the emergency department, and if they'd ruptured, well, they took their chances. So there were some surgical problems. There were some significant structural and organisational problems with access to imaging, radiology, set up for aftercare, etc., etc. And there were some very significant anaesthetic problems. The main issue there was that prior to 2005, the concept of dedicated vascular anaesthetists with clear governance, looking at what they did, didn't really exist across the country. We were still ad hoc. So NC-POD came out with a number of recommendations based on surgery, systematic and organisational problems with anaesthesia. But it hadn't made much of a difference. 3 years later, we still had an issue where actually the VascuNet report compared us incredibly unfavourably to the rest of Europe. Another reason why we shouldn't leave. But mortality in the UK was pushing 8% for aneurysm repair. And in Europe, it was around about 3.5%. And there's no comparable difference in the demographics of the patients or the training of the surgeons or what else is going on. And so the AAA QUIP program was instituted with the aim to reduce aneurysm mortality to less than 3.5% by 2030. They found that the main problem was this huge variation in care delivery and lots of places that were doing small numbers of aneurysm surgery, and that really drove the formation of hubs. So now if you're working in a centre that does vascular surgery as a vascular hub, It's very clear that you need to be doing a certain number of aneurysms a year by a smaller, more dedicated team of people, and that includes the surgeons and the anaesthetists. This was the driving point for the splitting of vascular training as a surgeon, and really the sort of creation, improvement in the recognition of vascular anaesthesia as its own subspecialty. It was also recognised that there was some really variable data recording. So although those numbers were fairly robust, there were plenty of units that didn't record data about outcomes or mortality. So to address that, they bundled together the care in hubs, like I said. They used best practice examples and care bundles, and we mandated outcome reporting via the National Vascular Database. Hopefully you're all aware of the NVD. This slide kind of summarises what's going on in terms of what the AAA Quick did. If you look at any of the boxes that have got the kind of dotted line around it, where the high intervention areas, and we've talked a little bit about risk assessment and pre-op assessment. What we're going to talk about next are really involvement in MDT and intraoperative care, and then the back end after the operation. So it's now an absolute standard that all patients having a AAA surgery go through an MDT process, and that MDT process involves preoperative assessment by a vascular anaesthetist, ideally at consultant level, and a consultant vascular anaesthetist input into the MDT. So if you're going to work in a hub centre, or you're looking for a job plan, or you go to apply for a job and your job as a vascular anaesthetist does not include some form of pre-habilitation, pre-op assessment or MDT involvement, I would suggest looking very carefully at that place as a place to work, because they're clearly not valuing your input. If we think about very specific intraoperative considerations, I told you I wasn't going to tell you how to, but I've put up some of the kind of, most frequently asked questions about aneurysm surgery and what you should do. One of those things is, how do you manage blood loss? Well, there's very clear evidence now that we should all know how to use and should be implementing autologous cell salvage during aneurysm surgery, adopting transfusion protocols and not overly transfusing, which I think we've probably got pretty good at. I think 10 years ago, you could give this talk and everyone was still giving lots and lots of blood to open surgery aneurysms, and they were coming out sometimes with better hemoglobins than they went in with. Probably not an idea. But into that, you add in the concept of preoperative transfusion pathways to identify those patients that are anemic and who are doing something about it beforehand, whether that's oral or IV iron or other things. I think an increased recognition about the importance of temperature regulation, but also the concept of avoiding that ischemic sort of rewarming phenomenon you get when you've had a clamp on. So you're not heating the legs while the clamp's on to generate more problems. There is not a standardized approach to the management of the cardiovascular changes associated with cross-clamping, but that's why I've said to you I wasn't going to give you a standardized approach. We all have a slightly different way of doing it, but there needs to be some way of doing it, and I think it's mandated that there's some form of cardiac output monitoring. And one of the key skill areas that I would suggest you all need to think about improving is your ability to do echo, whether that's transesophageal, intraoperatively, or certainly transthoracic, post and pre-operatively. So I would say that was an area that will change in the next 5 or 10 years, some piece of extra knowledge, skill in your armory that you should be thinking about getting. Increasingly now that we're doing more complex stented aneurysm, fenestrated aneurysm repair, and or if we talk about type 4 thoracic aneurysm repair, which is effectively an abdominal aneurysm, you need to be thinking about how you're going to manage the problems associated with spinal cord perfusion, whether that involves an awareness and a knowledge of the use of spinal drains, or neurophysiological monitoring associated with spinal drains, and automated systems now to remove CSF and try to maintain spinal cord perfusion. Again, I point you to that article in this month's BJA Education, which gives a nice little summary of that. Coagulation management at the point of operation, so point of care coagulation management. whether that be something as basic as ACT or ROTEM or TEG. That's a topic that I would expect people coming to a job in vascular anaesthesia to have an awareness of, and increasingly now move potentially away from central neuraxial blockade to these more WYSI cutaneous abdominal blocks, to sheath, QL, whatever it might be. Where's the evidence on that? Well, I'll point to some of that in a minute. So AAA QUIP morphed at the end of 13 into an ongoing QI program, which is still ongoing now, but which is the Vascular Services QUIP, if you like. It proposed and introduced surgeon-level specific outcome data. So you can go onto the VS QUIP website, just Google it, you can find out what Mr. Smith in the trust you work in actually has as his own individual mortality rate. Patients do that as well, and it's not unusual for me to meet patients who say, who's going to do my operation? And I say, it's a team approach, I can't guarantee it, I barely know, they barely know when they're scheduled to do it, but they'll say, well, I don't want him to do it because I've seen his website data. Some patients are that motivated, and that clearly should probably be part of a shared decision making. It's coming for anaesthesia. That will come for anaesthesia. AAA QUIP and VQUIP made a massive difference. In 2013, this quoted overall UK mortality rate for aneurysm repair fell to 2.4%. So from 7.5% to 2.4% in 5 years. That's an intervention that I don't see replicated in lots of medicine. That's a massive improvement. And you could say it was partly down to the fact that we were suddenly doing a lot more stents, and they had a much better 30-day mortality, and that's what was measured, and yes, absolutely. But the stated UK mortality rate for aneurysm currently runs at around 3.5%. This QUIP, the most recent up-to-date version of these kind of QI projects that I'm trying to give you this flavour of journey, is GIRFT. So the Getting It Right reviews, and there was a specific GIRFT for vascular. And the GIRFT take-home messages that I wanted to get you to think about today was how hubs are used, what we do to reduce waiting times, and the variations in costs and procurement. Importantly for us, prehabilitation. I think that's going to be a really major deal in the next 10 years, and a little nod to the data. So by July of last year, the hubs were supposed to be in existence, and to prove your mettle as a hub, vascular hub, you needed to perform a minimum of 60 aneurysms a year. You should have 6 consultant vascular surgeons and 6 interventional radiologists. Exactly, everyone's putting a face now at that. 6 of each. This is the vascular hub. Colchester is a vascular hub for this region. We tick a box on the number, we tick a box on the surgeons. We currently have 1.5 interventional radiologists. But we have some vascular surgeons that are dual accredited in interventional radiology. You should have a CT, you should have the ability to have a CT within 30 minutes of arrival in the hub, 24/7. You should have access to a dedicated theatre, and that should be a hybrid theatre, i.e. you're not doing your stents in the intervention room downstairs in radiology. You have a dedicated hybrid theatre within 30 minutes. That basically means you've got to have a theatre and staff on standby 24/7 if you're a hub. And there should be scheduled tick for here. I don't know, you can all do this mental ticking in your own heads for the places you're currently working. And there should be scheduled vascular operating lists at weekends. Costs. But we're moving towards that. Think about the resource implication of that as a vascular anaesthetist. Are you now going to be on a separate rota? Are you going to be on a general anaesthetic rota, or the ITU rota, or the vascular rota, or all three? And never see a family. Families are overrated. Waiting times. There's an RTT target now of 8 weeks for treatment after your definitive CT. So I don't know how many centres that you represent, whether you've got that 8-week RTT target met. Struggling with that. If you read the GIRFT, it's absolutely criminal, the variation in cost that the companies that manufacture stents in particular are charging. The variation in cost for a standard non-fenestrated stent is somewhere between around £4,500 to around 25 grand, based on the name that's on the front of the packet. Because there's never been anything, because all of those bits of kit have obviously been approved for use in human beings and obviously do the job of functioning as a tube that carries blood. But the snazzy nature of the aircon and the light that comes on when you open the door, all of that, and presumably where they were taking for dinner, it means that the costs, which is of course ultimately carried by the system and therefore carried by the patients, is something that GIRF really wanted to do. So there's now going to be, or should be, GIRF-led procurement strategies to try to minimise the cost. The cost of litigation is also not insignificant. So there's now going to be, or there should be from the middle of last year, a kind of standardised NHS litigation process should something happen. We gather data based on the National Vascular Database. That's that bit that you should also potentially be completing. There is an anaesthetic section of that and a surgical section of that. But when you compare that against the data that trusts actually measure themselves against, and which they send off to their commissioners to be paid for, which is called HEADS data, there's really quite a big difference. And that trying to change the difference in those two data sets is one of the GIRF principles here. I think that it will be a matter of very few years before we have, and if you look at MVD, you can get some form of anaesthetic specific data out of that, i.e. what is my mortality for carotid, what is my mortality for aneurysm. I think it will not be long before that is mandated in any form of revalidation or appraisal that I have as a vascular. And that's fine. I don't think we should have a problem with that. It encourages a good team working approach. All the work that's ever been done about publishing outcome data shows that. So there's a screening program in the UK. The screening program in the UK it should be aimed at people over 65, or if you're a man, or 70 if you're a woman. If the GIRF principle says that if you are screened and you have a small aneurysm, i.e. less than 5.5, you should be invited back for annual screening. If your aneurysm is over 5.5 on an ultrasound, you should be on a 2-week wait path, like a cancer pathway, to get your CTA to start that 8-week RTT path. We should be capturing 75% of all men over 65. And currently, in the UK, we capture 80% of all men over 65. So we've achieved that, but there's really some quite significant geographical variation. And the area that we work in, Colchester, is one of those areas that has quite a low pickup rate in screening. And there's socioeconomic reasons for that, obviously. There's also economic reasons for that, in that a lot of the screening has been co-opted out to private companies. So, what's the most up-to-date bit of aneurysm news? Well, it's the NICE consultation document that came out last year. It was just a consultation document, but it suggested some really very significant changes to practice and has prompted a lot of discussion. And you may have heard of it, you may have heard your surgeons mumbling about it. We should be mumbling about it as well, because it's going to have a really significant implication if it's adopted. Some of the headlines that came out of that were about the diagnosis, transferring emergency ruptures, predicting outcomes, repairing emerging complications. So in the diagnosis, there hasn't really been a significant change. It should be a screening program, 75% of men over 65 and women over 70. They should be encouraged to self-refer. So it's still not a mandated screening program, but they're encouraged to self-refer. And if they have one of those comorbidities, then they should be more strongly encouraged, if you like, and it's ultrasound screening rather than CT screening. If a rupture comes into an emergency department that is not a hub, there is no single diagnostic tool to predict which ones should be transferred. So you can't just look at a blood pressure or a biomarker or a CT result. You really have to just suck it and see. What NICE has said, and which is different, is that if you have a prolonged loss of consciousness or a cardiac arrest, you shouldn't be transferred because your survival is negligible, and therefore you should be on an end-of-life card. But whatever happens, you should be leaving your referring non-hub ED within 30 minutes. So if you're working in one of those hospitals that's not a hub currently, or the ITU bleep holder or whatever, and you're called, you must encourage our ED friends to stop faffing around. The concept of permissive hypotension is still considered to be reasonable, although there's no strong evidence for that. So the take-home message from that.
Do they make any recommendations about who should transfer the patient?
Staff-wise, no, not in that nice document. But if you're thinking about a 30-minute restricted policy and the fact that if you're unconscious, you're not going to survive, it does not need to be a doctor, does it? There is a large degree of Darwinian survival involved in transfer.
Because we used to have this with thoracic embolisms and stuff, or it has to be. It doesn't really make a huge amount of difference. If it ruptures and they die, it doesn't say it has to be an
It doesn't say, no, it certainly does not stipulate that it needs to be a doctor. It doesn't make any recognition.
So
who should
the
be transferred.
difficulty here having involved in one of these instances, when they die in the back of the ambulance, you need someone who's senior enough to say don't attempt resuscitation.
Well, no,
And
they leave the department with a normal resusc.
yeah, but that's not valid on the ambulance. If you fill in a hospital, this happened in the region, and big safety report, if you fill in a DNA CPR, they die in the ambulance, they'll try and divert to the nearest hospital, A&E crash the doors for CPR ongoing, and then they'll deny the admission, they'll be transferred back for CPR ongoing, and eventually they go around in circles, being dead for a long while until a mortuary will accept them.
So I think that's relatively easy to overcome, actually, because are you telling me that an ST4 in anaesthesia is the senior decision maker in the back of an ambulance?
It just needs to be someone that can say CPR is futile here, but paramedics aren't empowered to do that.
But yeah, I think that is a relatively easy one to overcome. I do not feel that, and NICE certainly doesn't say that you need to transfer to the doctor. I think if you had the resource and the manpower, then no problem. But if it came down to delaying longer than 30 minutes to wait for that resource and manpower, then that is going against evidence. The concept of somebody then dying in the back of an ambulance.
They must have that with other pathologies, though.
Yeah, of course.
Yeah, but they start CPR and they go, they've got a clear mandate, whereas say you have a cardiac STEMI and you arrest on your way to Papworth, they know what to do. They attempt resuscitation and take you to Papworth. If you're going on your way to a vascular centre and you have an arrest, then the correct thing to do is not to start CPR because it's futile, but they will because that's what they're trained to do.
Can't they just divert it to the nearest place, CPR fine?
That's what they did, but the nearest hospital said this is nothing to be
Well, that's
done.
the problem.
That's the problem at the hospital.
Yeah,
CPR go through the doors, the nearest hospital has some decision maker there who says, fine, call it. And you've not wasted the doctor to go.
So that would be ideal, but in the actual event that happened, the nearest hospital, not to do that, you were transferred to X hospital, you need to continue on to X hospital.
So it just needs to be added onto the list.
It needs to be,
where you don't have CPR, so they do have a list of
course.
parameters, and that just needs to be added to it, and that's it.
Something is valid.
Yeah. So NICE looks about predicting outcomes, and as much as I want it to be a single best tool, it isn't a single best tool. So CPET is not a single best tool for making risk assessment predictions, but it's probably one of an armory of tools, and it is formally recommended in this for shared decision making, as a shared decision making. So I think what that really says is that this is still a really valid thing to do. We should put to bed the concept that you don't need to have a CPAP. You absolutely need to have a CPAP. And of course, you should stop smoking and do all the other things, but nothing else really major headline there, apart from that bottom line about not starting beta blockers immediately before surgery. Well, we kind of need them, so that's fine. This is the big news. So the big news is that if you have a AAA of a large AAA, you should be offered repair. Great. You should be offered repair after you've gone through a prehabilitation course and all the rest of it. But EVAR is not recommended as first line. First line repair for aneurysm electively is open. First line repair for rupture, uncomplicated rupture, i.e. infrarenal rupture is EVAR, but under local anaesthetic. First line or best practice management for anaesthesia in terms of analgesia is still considered to be an epidural. So learn how to do QL blocks and take a view about the management of epidurals in your institution, and then think about it. However, if I'm now going to be going back to doing just opens, then I'm going to be putting more epidurals, because that is a gold standard that I'm afraid, with the best will in the world, rectus-sheath, QL, erector spinae, whatever you might choose, doesn't quite give that yet. You're still giving a lot of that. If you rupture and it's uncomplicated, you can have your stent and you can have it done with local groins, and monitoring and outline and all the rest of it. And those of you that have been involved in that know how messy that process often is. So open repair is back. EVAR for simple ruptures under LA is really the only indication. And that was through the improved trial, if you want to do it. Now, here's the big kicker. And the reason why that recommendation is made is that EVAR doesn't improve your long-term survival. It's associated with probably 20 to 25% re-intervention rate in terms of extending stent, either chimney stents or extended grafts, has around about a 15 to 20% incidence of endoleak, type 1 all the way down to type 4, and has an increased lifetime cost and therefore complications. So that's why we moved away from it. It's the recommendation for EVAR being dropped is effectively purely financial. So, so whether that in this consultation document is actually taken up or not long term, I have my doubts. And I'm sure we will still all be able to fudge sending our patients through stent repairs for a number of years yet. Take home messages. Open as a first line, EVAR for simples under local, CPETs for shared decision making, and use epidurals. Other things that caught my eye when I read that document that are interesting: increasing and probably obvious, fairly obvious evidence for the use of antifibrinolytics in rupture. So protocols associated with massive bleeding protocols where you're giving tranexamic. Permissive hypotension, well, we all know about that, but actually maybe we should be having some slightly more protocolized approach to how we employ permissive hypotension. And long-term macrolides and metformin for the reduction in aneurysm growth preoperatively. So not only do you stop smoking, but you put people on erythromycin and metformin. So it's a slow aneurysm rupture, slow aneurysm growth rate, and reduced rupture rates. So you might reasonably start to think, well, this is good, because all of a sudden I was sat in a clinic where I said to someone, you're really too unfit to have this operation. I think your life expectancy is in the next 5 years. This is what I do in my CPET clinic. Your overall health means you've probably got an estimated 5 years to live. But your aneurysm could rupture tomorrow. I know that's really terrible, but let's at least give you something that gives you some peace of mind about slowing the growth of the aneurysm, and maybe it won't rupture. And you'll die with aneurysm, not because of aneurysm, which is the line I use. And most people look at me and go, oh, I never thought about that. And go away, because the concept is, okay, I really, because most people come in, I really want this surgery. Whatever happens, I've been told about this sword of Damocles hanging over my head, this huge aneurysm, it's going to rupture. I know I'm 86. I know I can only walk 2 steps, and my home oxygen and my, and you go, I don't care if I die on the table. And I say to them, you're not going to die on the table, because I've been paid a shitload of money to make you not die on the table. But you will die in ITU on day 4 or day 6 or day 30, and it will be after agonizing pain and organ support, and then they get it. So the concept of dying with rather than off. So what are you going to do now? This is the last slide. What are you going to do now if I fire you up to be a vascular anaesthetist and you can carry out a joyous career in the NHS? You should all join VASPI. It was pointed out to me when I was first appointed as a consultant that it was slightly ironic that I was joining as a vascular anaesthetist, but I was not a member of the National Society, and that did seem to ring true to me. So I think you should join VASPI. They have an annual meeting. It's It's there. It's a thing. It's not that expensive. It's something that you should do. You should continue to maintain a really good logbook post CCT. It's really easy post CCT to go, oh, never have to open the LLP ever again or its equivalent. You do still have to have an annual appraisal, and it actually looks significantly better if you can demonstrate evidence of your continued involvement in this as a specialty. And start thinking about trying to draw off the NVD your operator-specific outcomes when you take that job. Between now and the time you get appointed and when you're doing your post-CCT fellowships or your credentialing or whatever's going to happen, if you get caught up in credentialing, you should think about getting involved in some decent quality QI. Some of you may well be, which I don't know, but whether you're going to get involved in true research or not, but decent quality QI. And if you think about what should I do, what's the standard? Well, you look at NICE, you look at GERFT, you think about those suggestions in those two documents as to what you're going to design your QI project around. And I would suggest things like shared decision making, use of CPET, MDT involvement, post-operative analgesia. Nice poster winner this year at VASPI was about the use of rectus sheath and QL blocks in post-operative versus epidurals. Look about something like times to leave A&E, who goes with them. That might be quite those sorts of things. Increase your skill base. Well, I'm an advocate, so I would encourage you to be advocates. I find it exceptionally useful and when I anaesthetize one of the aneurysms, to have met them in the CPAC clinic and been part of their journey. This is a really major surgery. This isn't, another hip replacement. This is a significant intervention of your time and effort. And when I'm sitting there at midnight on a Friday, I actually take solace in the fact that I'm doing something good for this individual, and I know them well. And when I CPET'd them, I knew that when their heart rate got to 140, they dropped their STs and their oxygen consumption. And so therefore, I'm going to make sure that I do that before, rather than just watching it happen and then intervene. So doing the CPET yourself and therefore learning how to do it, joining POETs or going on one of those accredited courses, that would be a good spend of some study leave or some post-CCT time. I think that the stethoscope is dead. I think the stethoscope is dead in almost all areas of medicine. And I think if you take a job up in the next 5 years and you can't do focused or fast echo, then there are post-CCT fellowships in vascular anaesthesia, and there is the RAFT organisation, which I would encourage you all to be involved in or look at, which is Research and Audit Federation for Trainees. And so those sorts of things might really boost your CV. Always say what it says, boost your CV. And that's it. I can take any questions if there are any. Shit, that's only 6 minutes left.
When the patient says, I don't want this surgeon doing my operation, I want that one.
Yeah, I have that question.
That's really difficult. I say that that surgeon level outcome data is really important, but there's variations in it because of the numbers. I say that it's a team approach, but it is shared decision making. And ultimately, if that's their decision, then that's their decision. We then have a slightly uncomfortable conversation at NET.
Is there really that much discrepancy?
Is that everyone, guys? Everyone's back? All right, if I switch the lights off, promise not to fall asleep. Okay, so this morning you had a bit of an introduction to vascular anaesthesia and what that may be like as a subspecialty. Obviously, all of you would have all been in a vascular theatre, hopefully. So what I'm going to talk about probably over the next 20 minutes is a little bit about giving you an idea of what is possible post FRCA. So apart from Barbara, everyone else, I presume, is post FRCA. It's going to grate a little bit on the ICM people because obviously you still have exams to do potentially, but so I call it the wonder years. A lot of you are probably too young for the wonder years, but it's after you pass your final, it's a great period, isn't it? You need to really capture the feeling of this is something that you were looking forward to since you were a novice. It's that final sense of gratification of working really hard, and it's all done. And that celebration, well, for me anyway, went on for quite a long time, probably until about SD6, and I thought, oh gosh, we need to do something now. But as that feeling kind of wears off gradually, you also hear like consultants and other people kind of around you saying, oh, so, what is your subspecialty interest? What projects are you going to do next? I mean, like, Vivek's come to us with the final FRCA, and we've just given him a whole load of stuff to do. So people start kind of then putting other things, other suggestions, other things that you can do in your path, and you're still reeling from just having finished, and you just want to enjoy the moment, which you absolutely should do because you need to kind of celebrate the victories properly. So this talk is going to kind of be in two parts. It's going to be a little bit about your clinical self. Have you seen Split? Oh, no. Okay, so there's two personalities, okay? So there's a clinical side of you because there's this expectation that by the time you reach SD7, by the time you're a consultant, as the consultants before were saying, they expect you to be able to be this amazingly calm, competent, assured clinician that can deal with a bleeding AAA with expertise. But also, there is this non-clinical side as well that is expected from you. You're expected to be a great teacher, to really inspire junior colleagues, be a role model. You're expected to kind of have some sort of managerial understandings. Like, how many of you would know who your service manager is in your division? Or the fact that they've probably changed about 4 times in the last 6 months. Also things like, things that complement your subspecialty interest. So earlier on we were talking about kind of regional anesthesia and scanning everyone. Well, if you want to have good ultrasound machines, then you need to be able to write a business case for that. You need to be able to present that in front of the capital projects group to deal with reps, bring the reps and organize things like that. Or in terms of if you're in education, need to get involved with the whole ARCP process, review training programs, things like that. So there's this whole other side to you as well. I hope I've not started putting any of you off, but you know, it's actually quite exciting. This is the fun bit. So we're going to do a little poll. Just bear with me while I switch my screens. So there's a if you go to menti.com, and enter in the code 655553. Yeah, I'll just open it up for you in a second. 6 5?
4 times 5 and 3?
No, yeah, 4 5s.
The one that you're showing is, I think, wrong. Yeah, 6 times 5.
Yeah, sorry, 4 times 5. Yeah, sorry.
6 5 5 3.
Yeah.
So
But this is 4 times 1 3.
Yeah.
6 4 times 5.
6 4 5s and a 3. Yeah, got it? So on that is a question. Do you know what subspecialty you'd like to practice as a consultant? So the choices are ICM, pediatrics, obstetrics, regional, pain. I know what I want. I know what I don't want to do. Everyone had a chance? Yeah, just one question. I'm just... So all 22 answered. So you can't see it on your screen, but in the results, so there's a spread. So 5 of you want to do ICM, 4 of you pediatrics, 5 of you obstetrics, 2 of you regional, and quite a good proportion know what they don't want to do, but not really sure what they want to do. Okay, so just going to go back to my slideshow. Okay, so you can see, you know, you're probably still undecided. So whenever you're going to kind of decide on a path you want to follow, you need to have a rough idea on where you expect to end up. And that might well change, but you kind of need to have a destination in mind before you set off on anything. And you need to plan it. Because before you know it, so you know, you might be SD 4, 5, before you know it, the years will pass by and then you're suddenly coming up to CCT. So if you want to do anything in particular, a lot of those roles require interviews and applying and things like that. You need to kind of talk to others, see what others in your region have done, but also plan how you're going to do it. You're going to have to plan it with the TPDs as well. And it doesn't mean that you take this straight, direct path up. It's completely fine to take the scenic route, to do lots of do lots of little detours before you end up at your final destination. And it might be that you actually decide that's not where you wanted to go anyway. In that detour, you found other interests and other things, and that's okay as well. So if we just look at the clinical opportunities that are around for you post FRCA, there's the curriculum requirements, right? You've all seen that. There's the usual spiral learning that you do from intermediate to higher. So you got your neuro, your cardiac, all the usual general units and ICM and pediatrics. And then there's all these optional bits, which are quite interesting as well. But where is the time in the curriculum to do all of that? It isn't there, isn't it? Because by the time you've done all your essentials and maybe done one optional unit or so, the time has run out. So what you're really looking at is fellowships. So fellowships out of training or post CCT. And fellowships obviously are in the range of specialties that we just put up in that survey. Gandalf has to be ICM. So what fellowships enable you to do is to kind of focus in on some subspecialties that you really want to get involved with. But it's got to be something different, hasn't it? It's got to be different just to your normal higher training. It's got to be added value. So fellowships will give you an opportunity to maybe do some research work or get some publications or get involved with a tertiary unit. So it's got to be something slightly different rather than just getting the clinical experience. Because you kind of need to justify investing that time in that particular fellowship. Like regional fellowships, it may be that you work somewhere which has a block room and you get that volume of work, but also then you kind of doing more work on things like developing pathways and checking different newer types of blocks, working in kind of a dynamic unit that's really focused towards regional anesthesia. In head and neck centers, for example, you get really skilled at kind of managing the really complex, difficult airways. And we'll talk about research fellowships in a bit as well, and a few of you in the room have done that. So in terms of clinical, where are the opportunities? And the theme of this talk is going to be looking at things locally, regionally, and nationally. I just want to give you an idea of what is available. So in terms of clinical fellowships in the region, there is actually quite a lot of opportunities available within the hospitals that are already there within your region. And the best place to go and look for that is on the East of England Anaesthesia website. You can see that this gets updated periodically, and they put in various advertisements there. And then there's all the national fellowships as well. So that's obviously a little bit restrictive depending on your personal circumstances. But if you are prepared to travel out of the region, then there's opportunities there in specialist centres. And then if you're looking more towards kind of an OOP or a post-CCT fellowship, and you're able, circumstances allow you to travel abroad, that is a great way to consolidate your learning and your clinical skills, going to a massive regional centre in North America, or doing kind of simulation, or being the malignant hypothermia research fellow, or going to Australia, to places like the Royal Melbourne Hospital, and doing fellowships there. So the opportunities with international fellowships are really, really remarkable. In terms of anesthesia in developing countries, the best place to go to look for opportunities with that is there's a global anesthesia fellowship, but also the AAGBI and the college both have a section for trainees about out of program experience. And also, have any of you gone to this website, anaesthesiafellowships.org? So it doesn't project onto there, but if you go into your, just on your phones and click on anaesthesiafellowships.org, you will see that some trainees have previously listed all the subspecialties and what's available, where it's available. So if you go, say, for example, into obstetrics, they list all the obstetric fellowships in the UK and internationally. So again, there's that opportunity to look at what's available. Then there's a little report that someone's done on it as well. So there's a lot of work that's gone into kind of that website, and it'll give you an idea of what's available both nationally and internationally. So in terms of what's expected from you non-clinically, anyone know where you could get an idea of that from? How that is mapped?
There's a whole annex.
There's a whole annex. So Annex G is about all the non-clinical things, right? So by the time you finish as a consultant, by the time you CCT, your training portfolio needs to have elements of management, elements of research, elements of QI and teaching. But although it needs to have elements of that, you should also have your own special interest that you delve into deeper, because this is an opportunity, isn't it? The post FRCA years that you have, it's really a time to go into what you really enjoy doing, what you want to pursue further. And this just gives you a guidance, and you should do a little bit of everything, but really focus on what you enjoy. So if you are, really into quality improvement, look at opportunities surrounding that, look at perioperative anesthesia fellowships, things like that, or masters in quality improvement, and really focus in on that, because once you CCT and you go into an anaesthetic department, it's amazing, because then you're going to bring all the skill that you've gained during your fellowships, during the latter part of your training into that department. And which department wouldn't want that? So let's have a look at academic and research. So the college has, like the minimum mandatory competencies in terms of kind of going to your local journal clubs and MDT, maybe doing a research methodology course, or just taking it a bit further, doing a few case reports, doing some guidelines, doing some work in order to change practice. So these are kind of the basic expectation in terms of Annex G. But what can you really do to kind of fulfill that part of your portfolio? Well, you can do small things locally. So you can be the local trainee lead for all these various projects that come around, like SNAP or the NAP 5-6. Be a part of your local trainee network, research network as well. And they bring about lots of multi-centre projects, and you could be the lead in your trust for that. And a lot of trusts are now signed up to PQIP with the college. So it's perioperative quality improvement, and all trusts are signed up to NELA. So you could be the trainee lead for NELA, could be the trainee lead for PQIP. And the last two are actually perfect, because the data analysis is done for you, and they give you your quality improvement targets as well. So it's really a good way to do a QI project, but also kind of dip your toe into the research world as well. Obviously, one of your colleagues will know a lot more about this than myself, but there is an opportunity to to do a year attachment at the Division of Anaesthesia at the University of Cambridge. And that will be spending a bit more time doing a proper research project that's funded, but then that will take you through the process of writing out ethics approvals, going through that whole process. So it depends, again, like I said, you can do a little bit of everything, but delve deeper into what you really want to go into. So it depends what part of the research spectrum you feel you're on as a person. And one of the questions that always comes up at consultant interviews is, should all anaesthetic trainees do research? And of course not. It's not practical, it's not possible, but what's expected is that you understand the basis of research. You can critically appraise the literature that is there surrounding a certain topic and know what good practice is to follow. Maybe you can supervise a junior trainee undertaking a simple project. So doing things like that will give you an understanding of it. But obviously going further, that step further, and spending time actually doing a recognised research project will help you further. Okay, and then if you want to take it another step further, nationally, there's the HSRC, which is run by Ramani Munasinghe at UCH and the college. They have research fellows that they advertise for, and that comes up on the college website quite a lot. And those research fellows are appointed to a hospital where they do kind of their on-call commitment, and their daytime commitment is getting involved with one of these, this kind of project, whatever it might be at the time. So again, if you do a project like this, you get to work on a larger scale with large, big data. Again, that gives you a lot of experience. And also working with people that are influencing anaesthetic policy and care and things like that. So this is what the Annex G has to say on quality improvement. I think all of you from a very early stage get involved with quality improvement. But again, at a local level, what can you do? So there's a lot of departments are working towards AXA accreditation. Again, there is a whole set of guidelines for the provision of anaesthetic services. So what you could do is take one of those guidelines and see how that department measures up to it, and the improvement will be where they fall down against some of those guidelines, how you could bring the department up to the standard that is expected. Another really good website if you're looking for quality improvement tools, but also there's some really good case reports on quality improvement. You might have heard of the Healthcare Improvement Studies Institute. If you go on there, again, they've got fellowships. They've also just got some really interesting case reports of QI adapted locally, and also really good tools there as well that you can use in QI. Has anyone seen this before? Okay, so moving on to management. So you could just go and do the Keel management course, but what does that really give you in terms of equipping you to be a consultant or developing you personally? Not very much. So what is better is to actually do a management project or get involved with management locally. So every trust has to have a junior doctor forum. So as post FRCA trainees, actually you're some of the most senior trainees within that trust. Okay, and senior trainees are perfect for representing the other trainees at the junior doctor forum, because not only can you see what's going on at that trust, you've been to a lot of other trusts and you know what good practice looks like. And so where you see things can be improved, again, the junior doctor forum, there's opportunities to escalate up to higher management. So there's opportunities to work with the medical director, with the director of medical education, or the guardian of safe working, and get involved with kind of that side of management to improve the basically the conditions for fellow trainees. But again, that's a little management project that's actually quite interesting because it's trainee related. You could be a trainee rep on your actual anaesthetic faculty, so you report back to the educational supervisors, and regionally, I'm sure you've all heard of the Chief Resident Management and Leadership Program that's run from Cambridge. It's free, so your college tutor or your director of medical education will email you or let you know about the program. But if you go on the website also, you'll find out when their next recruitment rounds are. Generally tends to be around August when people change over. And that's a great program because it gives you some workshops. You do a project, a small project that lasts for about 6 months or so. You're the trainee representative on the Junior Doctor Forum. Also within the school, you can be a trainee representative for kind of the School of Anaesthesia. You could be the LTFT trainee representative as well. So there's lots of opportunities there to kind of get involved in management. If you go to the NHS Leadership Academy, there's the Mary Seacole program, which is a program that you apply for. You submit like a kind of a 500-word submission saying why you want to do it, things like that. So it's a distance learning thing, but there's some amazing face-to-face workshops as well. So that's brought by the Faculty of Medical Leadership and Management. That lasts a year. That gives you a certificate in medical management, and again, you do a project alongside it. So it's not that a case of just going through the management process, but it's actually doing a project using the skills you learn. Nationally, once a year, there's opportunities to do the National Medical Directors Clinical Fellowship Scheme, which again affiliates you to organizations like NCPOD or the GMC, so like big national organizations where you do research projects and management projects that are relevant to you. And then, there's GAT and the college, they nationally look for representatives, and there's no reason why you can't put yourself forward to do these roles, because it's exciting, it's national, it's representing trainees on a national board, and you'd be having an opportunity to influence what happens to future colleagues. So left the best for last, obviously is slightly biased, but medical education is really great because it can integrate all of those things. You can do things related to QI and medical education. So, for example, there's a lot of QI projects that involve teaching, seeing where teaching maybe could be improved or delivered better, and doing a little project related to that. There's also things like the foundation doctor teaching, medical student teaching that's available. You also have a new medical school that's just coming up to a year old at Anglia Ruskin. So, it's a great opportunity to really get involved with that. Some of you may be involved with it already, but it's important to kind of form links with that medical school if you're interested in medical education, because over time you can get involved and do things and be a clinical tutor there, be a supervisor. Again, there's loads of opportunities that are available. So locally, as I talked about, you can run post-FRCA study days, deliver simulation teaching sessions. So Lucy's been involved with today. Run local novice teaching. If you think the novice teaching program in your trust could be improved, then you could set up a little novice teaching package. You could set up a little introduction to obstetrics package that has a bit of simulation, a half-day workshop, some lectures. There's opportunities to do programs for other healthcare professionals as well. Regionally and nationally, so there's lots of simulation fellowships. We run one here, there's ones in Cambridge. A lot of those simulation fellowships, for example, the one here are linked, you get a free postgraduate certificate in medical education that comes with it. You could organise regional training events, so like you can organise a regional trainee wellbeing day, so if you get a consultant supervising you, and run it for all the trainees in anaesthesia in the region. A really good website for medical education is the NAT website, which is the National Association of Clinical Teachers. Okay, so you can see that it's really exciting because there's loads of things that you can do to develop yourself in terms of your clinical skills and your non-clinical skills. Like I said, it's not one part, it's what you choose to do. So you can see what opportunities there are, and you just build that up slowly, coming up to your CCT. So now we're just going to move away from that a little bit and just talk about something slightly different, which I found when I was coming up to my CCT. So when you get your final, actually your confidence is really, really high because you think actually you've proven that your knowledge is very good and it's been tested against a very, very high standard, and you've come up trumps against that. And then you go along and you're doing all your subspecialties, and then your confidence is still really high. Gradually you're coming up to a CCT, and your peers are also talking about what they're doing, what jobs they want to go for, and what things they can do. And then suddenly you just start feeling this little bit of insecurity starts creeping in. Actually, like, am I good enough? Can I go on to be a consultant? And I thought I'll put this in because I went to a workshop for actually college tutors and TPDs a couple of weeks ago. And there was a really interesting talk about imposter syndrome given by a lady called Kate Aikens. She does a lot of talks for within the region on this thing, but also I think nationally. And I thought I'd put this slide in. So what she was saying is, there's two. So the y-axis is your perceived ability, and the x-axis is your actual ability. And so you can often see trainees that maybe are coming to the end of their first year in anaesthetics, that they display potentially some you may know some people that display the Dunning-Kruger effect, which is that you basically don't know what you don't know. So you have a bit of ability, but your perceived ability is a lot greater because you don't know what could go wrong. But as you get more senior, you've seen what can go wrong, but more self-doubt starts creeping in because you can see what, especially where you're stepping up from, say, an ST7 to a consultant level, because you're comparing, when you talk about consultants, there's a spectrum, isn't it? From someone who's just a one consultant to someone who might have been a consultant for 7 years, and you almost feel a bit of an outsider to that table as you're stepping up to the next level. And imposter syndrome, it's more prevalent probably in women, but men have it as well, and it affects about 70% of people. And if it is really bad, it's something that can cause you great anxiety. And what you should try and do is just recognize that that feeling of imposter syndrome is going to be quite high as you come towards your CCT, as you come towards your interviews. If you go to your first interview and get it amazing, but if you don't, then you feel even more of an imposter because you've had a little bit of proof that in your mind you feel that actually, am I suitable for this? Have I done enough? Nothing seems to be enough. So just thought I'll touch on that. So a good way to deal with that is actually to find a mentor. Okay. So a mentor you just need a friend. Right? But a mentor is someone that you may already have a mentor, someone that kind of points you. They don't tell you what to do. They know you as a person and they point you gently in the right direction of where you should maybe think about heading, give you ideas and opportunities, and the mentor needs to align with you and your interests and the kind of person that you are. But especially in dealing with with imposter syndrome and with knockbacks you may have, it's really good to have someone that you can just have a chat with when things don't go quite so well. So, how many of you are on Twitter? When I was preparing this talk, I wasn't being lazy, but I just thought, actually, Twitter is a great platform for making kind of professional connections, for sharing knowledge. So if you're not on Twitter and you can bear to be on social media, it doesn't break you out in a cold sweat, then I would recommend going on it, because just in terms of medical conversation that takes place on Twitter, it is very interesting. You have to ignore, so apologies to any pre-hospital medicine, but you have to ignore the kamikaze pre-hospital medicine chatter on there. But generally it's very useful. So I put this post up just to see what response I would get, and I thought I'd share some of the top tips on that. So if you could go back in time and give your post-FRCA self one piece of advice, what would it be? So we talked about this, have a plan or two, but keep an open mind to new opportunities. And then the second one is really important, and that should go for throughout the rest of your career, really. So especially now that you've passed your FRCA, people are going to offer you, all meaning well, but offer you loads of projects and loads of things to do. And it's great, but you really have to pick maybe maximum 2 or 3 things that you're going to do, because you don't want to take on projects and not deliver on it, not finish it. So you should start saying no very politely, and then really focus in on what the projects that you do want to do, and do that to a high standard. When you look towards, like, a bit more into the future, towards your consultant jobs, when you apply for a job, you tend to focus in on the job plan and the subspecialty. But the thing is, job plans change over 5 years. That subspecialty might go off to another hospital as reorganization and the NHS changes. But what doesn't change over 5-10 years, well, the location will hopefully never change in terms of, they're not going to pick up the hospital and put it somewhere else. But your colleagues aren't going to change either, apart from maybe Patchwork. It's not going that far, is it? So really, location has to work in terms of your family, kids, friends, your support group, and then colleagues, I would say, even more than location. Colleagues make the most difference to me anyway. So again, this reiterates that the people you work with and in your life are more important than the actual job plan and job description, because that's what we get really focus in on. And this was my favorite one, so I'm just going to end on this one. And this is kind of underpins what I was talking about before. Don't rush in necessarily just to finish on CCT. I know that lots of you may have done other jobs before, other training programs, but this post-FRCA period is an amazing opportunity that you can try lots of other things that are available out there. Because once you're a permanent consultant, it's more of a faff to get sabbaticals and things like that, and it's difficult, you're more settled. And also, if you do have kids, so from my perspective, I had my first child after I finished my final. But before I went on mat leave, I'd applied for the air ambulance, the London Air Ambulance, and I got that post. So I told my TBD that I'm going to take 6 months mat leave and come back and do the air ambulance job. And she said, okay. And that was that. But it was very obvious that, one, I wasn't going to take only 6 months off, but I wasn't going to come back and do an air ambulance job. So, take that time. Go, if you want to go into flexible training, don't rush through and finish the thing, just quickly become a consultant, because that is going to be another 4 years, and then the children are 4 years older. So just take your time to enjoy your life as well as doing your training. Yes, it will extend it, but look at all the amazing things I showed you that you could do to extend your training. In summary, hopefully I've shown you how you can develop yourself clinically and non-clinically, what's available both locally that you might not have seen or realized necessarily. Amazing stuff available within this region, but also nationally. And just think of some ways that you can develop yourself, because I think having the FRCA is almost like having a passport to go and explore all the wonderful opportunities that are available within the specialty. So it's important that you make the most of that. That's it. But that's my Twitter account. That's my password. I'm going to set Sue up for her talk on carotid management of carotid aneurysm, carotid surgery. But if you have any questions, I've just put the light on. And I'll take any questions.
I should have learned to say no.